like to remind all of you for some important points, which is speaker presentation time will be of 30 minutes. Keynote presentation time will be of 15 minutes. Asked and answered session is allotted after the end of each session. If you have any question, you can communicate it through the chat point privately, or you can put your questions on the chat box. So let us welcome our keynote speakers, Ms. Susanne Burgess. I hope that I mentioned the name very well, from Switzerland. Ms. Susanne has completed a master's degree from Raeburn University. She has over 30 years of nursing management experience in different organizations and is now in the lead of digital standardizing nursing documentation through Europe. Her presentation will be collect ones, use many from nursing intervention, the relevant KPI in the EPR and beyond. I'm passing her the stage to deliver the keynote speech. Welcome, Ms. Susanne.
Thank you very much, and I think it is quite a nice follow-on from our last speak to actually show you to how we actually do a transition from the nurses' satisfaction into analyzing the data that we can collect from documentation. Therefore, I would like to actually share my screen with you. So my topic today, what I would like to talk to you about is, and also a way of proving the nurses' appreciation for what they're doing. And we heard this morning quite a lot about safety of the patient, safety also in terms of pandemic, how we can actually care for our staff, and how important that is. We also heard on reducing, in terms of the lean management, reducing the handover times. And I think what I would like to demonstrate in my talk to you is how this actually has been done now for quite some years, especially in Central Europe, in terms of out of the nursing documentation. Whom I work for is a provider of a classification, especially for a nursing language, and this is nothing new. This is nothing in out of the world or something that has not been done yet. And I will show to you basically on how one can actually use a standardized nursing language. We have established this course of action now nearly 40 years ago. We established now in over 750 institutions throughout, especially Germany, Switzerland, Austria, parts of Italy as well. And we're now looking at expanding to France, to the Scandinavian countries, and so forth. And we are available in 4 different languages, as you can see: German, French, English, and Italian. And of course, every country that would like to use our nursing classification can do that. I would actually like to start a little bit earlier than just jump in with a nursing classification. And I think if we want to have all this bound up in one topic, we have to see what's going on in our electronic or digital world actually. And I think what we always have is this kind of wish in our clinical device that we have a massive amount of structured data. If you think when you're using electronic data, your clinical information system, where in the whole of this kind of computer world we use data, that is the ideal world. We have this kind of structure and we have one little drawer for every information that we collect, so that in the end, ideally, we can analyze the data. But unfortunately, I have to say, and I think you can relate to that, that is also mostly the world that we envisage in this kind of clinical data set. We have a lot of information. If you think who is collecting what, are the physicians, the physiotherapists, the nurses, anybody who is actually in contact with the patient collects their prominent data, but in essence, it is also information that we ask the patients twice, 3 times, and so on, or it is actually somewhere hidden away in this whole clinical information system. And unfortunately, we can't, or somehow often there is no possibility to actually gather it back so that we can make best use out of this data. But moreover, we also have a lot of stakeholder in these data. If you think what especially nurses are gathering in information, there is, we heard it before, we have interest in terms of the financial data. We want to actually have a cost benefit out of it. Nowadays, a lot of it is actually related to the cost, the length of stay, and how can we now actually have all this under one belt, that we can have the satisfactory data analysis that we use.
Sorry, Ms. Susan, I would like to ask you if you can please enlarge your slides.
Sorry?
I would like to ask you if you can enlarge your slides, please.
Okay, is there something?
Yeah. Mm-hmm.
Is that better?
Okay, that would be better. Okay, I will. Okay, Miss Susan, enlarge for option is in the right corner, please.
Mm-hmm. Is that better?
Actually, we want to see all of your slides. So you can press the option on the right corner of your PowerPoint slides. No worries, we will share your slides. Next.
Okay. Yes?
Okay. Yes. You can start, Mr. Susan, when you finish, but please say next, so we can go to the next slide.
Yes, you can actually just go on to the next one. Okay. Sorry about that. That's typical. The keynote is not working. Okay, yeah. So we have this kind of all use of different data, the stakeholders I was talking about. In that case, we have the medical colleagues who are interested in our data, as we often ask the patient relevant information about his health status. And as you know, we may see them first, and then our medical colleagues take over, and they might ask them often the same question. We have the financial part of it, that we want to know how much, or is this kind of patient or this setting of patient, is that relevant? Thing that pending if we're a non-profit or a profit organization, is this something that we actually want to care for? Are these kind of the surgeries, the operations, the inpatient that we would like to treat in our hospitals, that we get the revenue that we would actually like to have? And in that case also, when it comes to staffing, of course, the nurses, as usually in a hospital, as the biggest setting of staffing values, we also have to see, do we have the right nurse with the right education in the right place at the right time as of the patient? So what we have here, basically what we have developed, is out of the nursing documentation within a clinical record system, this attitude that the nurses can actually document what they're doing on the patient, but at the same time, we take those information out and we share it in the end as a clinical analysis tool. So if you could go to the next one, please. Now, what am I talking about if I say a standardized classification? If you look maybe in your own hospital, you have a lot of paperwork, or you have a lot of different information, and it is all how we're going to take this or retrieve this out of the clinical documentation. And as it is Easter, I have this bowl of wonderful chocolates here, and they're all mixed up. And usually this is the situation which we find in our clinical information system. So it is so important then that we up and foremost have them grouped in different kind of structures. So please, I will just say please, and then if you could go on. So we have first to have this structure of the nursing activities. With nursing activities, I mean this is all the intervention that we nurses do on a patient on the bedside, embracing the full spectrum of our activities. And secondly, please. We need to have this planning and proof of the implementation. So basically, as we heard before, also in this kind of handover, if we have a competent planning system, there is also a very easy approach to see what is planned with this patient. We can actually look into the future. We see what this patient needs. Also, you can imagine that we have patients that may undergo a very standardized procedure. So this is also something that we can have planned in terms of a checklist. Do we actually have the right measure for all the patients in place, or does the patient actually need any additional help? Also, from a legal point of view, we need to have this kind of proof of execution, that we can actually in some way really prove that we have done these issues, because as you know, this is more and more also a problem, that this legal side, are we actually really fulfilling our duty, or have we actually implemented or executed the issues that we were asked for? Next one, please. And also in the last sense is that we don't want to actually have all this done once or twice or 3 times. We don't want to have different forms that we have to fill in, but we want to do it once, collect once, and therefore all the other stakeholders that we have should please just use what we have already documented once. Please, if you could go. So what I'm talking about is that we have a documentation of nursing interventions, and also this is not just on one side, but we also have to see that within a hospital or hospital groups or whatever, that we actually have this standardized language for all different settings. So I'm talking from the inpatient wards, from the IMC to the ICU, to long-term care, secondary care, but also into nursing homes, into the primary care setting, that we can actually have the same kind of language also to do an additional benchmark, to see also in terms of quality assurance, what does happen from one setting to the other. And also not only for the nursing group, if we want to calculate costs, you can imagine there's not just the nursing actually working on this patient. We have a lot of other professional groups like the speech therapy, nutritional advice, dietitians. Then we have the whole social services. So if we want to actually really calculate the effective costs, we have to embrace the whole package and not just looking at nursing. So the last setting in, please, is the application that we are looking primarily at the nursing process, but also very importantly that we can actually have this kind of individual planning of patients. And many of the institutions use their pathways where the patient actually has in a dedicated standardized way that we know very well. He comes from for something minor, the problems, he's a healthy patient and he just needs according to a pathway, his treatment in nursing, etc. So we want to actually honor that, that we can actually have these pathways very well laid out beforehand, so that it is very easy for the nurses also to go through the documentation in a standardized way. So in the next slide, I will actually like to show you this on a theoretical basis. We're talking about the classification of these healthcare activities, which is more or less the overarching process of it all within an electronic patient record system. We have the case data. The case data that, of course, can be the medical record. The case data could also be what we know with what kind of treatment the patient comes in. Then we have all the additional information from the institution. This often is the internal standards or regional standards that nursing in itself have to adhere to. And of course, then the classifications of the individual groups. You know very well that nurses have one language, the midwives use a little bit of different terms, maybe for the same issue, and also with the physiotherapists, they take over many workload from the nurses and vice versa. We always have the issue of the weekends. A therapy, is it then conducted by the nurses? Is it conducted by the effective physiotherapist? So we also have to embrace this kind of different classification and different languages of each professional group in this kind of standardized documentational framework. And then, of course, something which is very, very important, and we heard it already this morning, is the actual working hours or the labor time of each occupational group. And this may vary from hospital to hospital, especially from country to country, on how many hours the endurance of a shift, endurance of how many working hours within a week, within a month, because that is also the framework. Well, if we talk about having the cost value of our nursing hours or of the occupational groups, we also need to know how much they work in order to calculate all this. So this has an influence on the patient documentation. And here I'm, of course, not talking about the patient documentation on paper that only works in a digital environment, where we can actually summon all this and embrace in one big framework. Out of this, what we can then see is the whole workload measurement. So we want to see at the end of the day how much time has been spent with the patient, how much individual intervention have been done with the patient, so that we can have these kind of KPIs, this analysis in the end, which comes from an entire different area than what we are actually used to, so that we can prove to all different stakeholders what nurses actually are doing. And I can tell you, not long ago, it has been about 20 years ago, we had this comment of a politician who said the nurses aren't doing anything else, they're just sitting in their office and drinking coffee. And I think that was one of the most befriending statements ever, and now we can actually prove what nurses are actually doing. So if you please, the next slide, please. Now, if we talk about a structured approach to a nursing classification, which can actually be used in an electronic patient record, what we need is also a framework of classifications, not just like a regional or even house internal individual level, but also that we are able to make a connection or a linkage to languages or classifications that are well known and also well recognized by the WHO, etc., and other institutions. So that is very important if we want to actually have a patient documentation that is not only usable for internal purposes, but also in terms of a benchmark, or like we are here today, that we can share this data also on an international level actually. So as you see here, the nursing classification that we use at the moment is mapped to ICF, ICMP, and many more classifications that you may know already. So next one, please. Next one, please. Yeah. So one thing that we have done, and I think especially now with the whole analysis of the COVID pandemic, that we have mapped our nursing classification with the terms of SNOMED. And you will see here some examples of this, and you see how close the two languages actually present themselves. And I think being able to work within SNOMED, with ICMP, sometimes for the staff at a level that they actually document or what they actually use on the bedside, it is a language that may somehow is a bit not in a content that one would actually use in a day-to-day basis. And I think what we try to do is take this kind of very scientific approach of these languages and turn it into a classification that is far more, I might say, to the heart of a nurse. This is more like in a language that we may also talk to one another, that we may also just record, or just from a historic point of view, that we may also do our recording, might it be in an open text session or whatever, on paper or in a digital environment, so that we can actually understand each other a little bit more, or it's easier for them to work with than with a more scientific standardized language. But the advantage of this, of course, is because the classifications in itself, like with SNOMED or with ICMP, they're so close. So basically, we can map one classification to the other, so that in the end, when it comes to the analysis point of view, we can actually draw out or exercise all the analysis data that we may need for a SNOMED analysis in terms of COVID, for instance, but we could also have a lot more detailed analysis in terms of the nursing outcome from the classification that we use, which is more in terms of KPIs within the nursing setting in itself. So let me just, the next slide, please, tell you a little bit, or just let's actually go into the practice of this whole session of nursing documentation. When we look at what nurses are documenting, or when we go to the theory of the nursing process, it usually starts with an assessment, then we have a nursing diagnosis, we have an aim, what do we want to achieve with this patient at any given time, or with his disease, or the problem that he presents ourselves in the hospital. And after having this determined together with the patient, we heard it before, we have this kind of reporting on the bedside, and we then determine all the nursing care activities which are necessary to achieve our goals in terms of getting the patient better, or basically that he can be stable, or whatever environment that we have processed in terms of the aims of his stay. And so basically from this kind of planning side, We then go over to the execution of these nursing activities. And of course, to round it all up, we have to evaluate. And you all know that nowadays, with like what I said in beginning of my talk, that the cost factor is more and more important. We have to have the best ratio. So the evaluation of what we have been doing, is this what we actually have done with the patient or on the patient? Was the right treatment, the satisfaction of the patient, etc., plays an enormously role now in the nursing care process, so that it is actually a cycle that then starts again if we have not achieved what we wanted with the patient. So this all is actually now implemented in this kind of nursing documentation cycle. And the next slide, please. What we have is we concentrate on the activities that are actually done at the patient. And I tell you, if you think, and I think you all can relate to this, what we as nurses or anyhow in the hospital have to have done now on paperwork and all different kind of forms that we have to fill in. So what our aim is to really just focus on the patient activities, what is actually done with the patient. And you can imagine that there is so many other things in this whole of treatment. We have all the issues that we have to fulfill, that the service is actually going on, and from the planning, we heard it before, from the handovers, the team meetings, we have a lot of research that we have to do, but that is all one thing. What we, in the nurses documentation, what we want to focus on is really the activities that we do on a patient. You see this here, it's the time that we spend on the patient, it's the procedures like the washing, the whole medication, it's the whole time spent with him, with the relatives especially. So that is the model what we have. On the other hand of all this, is also very important, you see this in this orange slide as well, that we can only, if we have a shift of 10 hours, 10 hours is what we can actually allocate to the patient. You can do overtime, but in an ideal world, it is those 10 hours what we can divide within these three different factors. So when we go further, I can show you an example of what this classification actually embraces, please. Next slide. And now this is what I would like to show you when I was saying about the actual language in this nursing classification. What you see is that we always provide a definition, because not every intervention is so clear in the title. Maybe there are some that you actually have to read a few times, that you actually really have to know, is it the right idea? Do I have the right idea? And I think that's also, if you look at what nurses are documenting in their environment. Sometimes it is maybe not quite the right expression used, especially we heard it before, if you have a lot of foreign nurses, the language might be a real problem on how things are written down. So with the standardized intervention, you have a certain amount of quality assurance as well, that the right title is given to the right information that has been done on the patient. Also, what we're saying is that the level of detail on somehow, if you find in your documentation, is it really the right level of documentation? Yes, we have to have a legal framework, and yes, we have to document quite a lot, really, but at what level do we actually want to have our documentation at? And what we advocate is that in the framework, when we have a clear definition, we have a clear idea what is included in this task as well. This framework, if there are any clawback questions or any legal questions with it, you have this kind of framework of explanation, of definition, where you can have a look at what does it really entail. Also, and now we can always now move into the section of the analysis. What you might find in the title, there is this D9, this number. And this is the clue, I might say, in this whole documentation. If I was talking about the standardized and also automatic documentation of nursing interventions, this is to every intervention is a matched time frame. And in the 80s, when we started with this classification, what we have been doing is really going along with the nurses with a stopwatch. And that was the first attempt to really time how long does a nurse take to have a bed, do a bed bath, to do toilet training, to do mobilization into a wheelchair, so that we had a first understanding on how much time do we actually use for an initial task on the nurse's workload. The next slide, please. Now, in this documentation, this is a slide from a clinical information system. I can also tell you that we work together within the whole of Europe with about 30 different clinical information system providers. And in every clinical information system, the implementation of this nursing language or how it is used in the end for the documentation looks a little bit different. So this is the slide where I would like to show you all the different groups. You remember my slide with the Easter eggs, and this is how it actually now transfer in a practical setting. What you see are the groups, like the movement, the personal care, nutrition, because when we want to document something, we either have the possibility to actually go into these groups and share any of these intervention. You see this kind of personal care now is open, and you see a selection of possible intervention that I would like to do as a nurse. So in this stage, what you can say, you have the patient, you've done an assessment, and going back to the nursing process, it is also possible to actually have these individual nursing process blocks, so to speak, interlinked with one another, meaning that if I have a standardized assessment or the house uses, the institution uses its own standardized assessment, that I can actually have a linkage between the assessment to maybe a nursing diagnosis classification like ICF or NONDA International, and then to the intervention, so that the nurse is guided through this nursing process. And here you have this transfer into the clinical information system. So here you can either choose what you are going to do with the patient individually, and you can actually cross on what your task is going to be. So please, the next slide. And to plan, we have to have the nurse, of course, and this is very important for another analysis. We use usually an individual login, so this is already locked, so you know it's a nurse. It's a nurse with a bachelor degree, it's got a master's degree, it's an auxiliary nurse, or whoever it is. Then the interval, that is how often is it going to be done? Is it once weekly? Is it twice daily? Or how often is this going to be done? Now, I don't know. Yep. And in means and objects, this is basically, do I want to have some other materials attached to it? Do we have standardized medication that we use? So this is all basically in one overview in this kind of planning cycle on what I do with my intervention. So the next one, please. So you see this, which is now actually filled in, and you see for this performing a partial body wash, because this patient allegedly was a very heavy patient. We even used 2 nurses, and you see she has been added on our screen. We have changed the duration of this partial body wash from an approximately 15 minutes to 20 minutes. And what we can add is that we can say, in this case, the patient displayed a lot of pain, or you can add something like the patient likes to be showered with a special type of body lotion, or whatever it is. But you see, in this kind of planning stage, you can actually have any kind of relevant information on the patient there, so that in the end, in the clinical information system, you have all the relevant data there. So the next one, please. Now you ask yourself, I was talking about this time issue, and that we were collecting the data right at the beginning with a stopwatch. Nowadays, now in 2020, we don't do that anymore. What we do every 2 years, we have this very big study going on, and we collect the data from, now it's over 20 institutions, the one that we're actually doing at the moment. And we take 6 months data and take all the different intervention and have those analyzed on a statistical data to see what is the mean, how long does a nursing intervention take in different settings, because you can imagine that especially if we stay with the bed bath given, it is probably different if you're in a reconvalescence setting, or in a surgical environment, or let alone in a old people's home. So you have this kind of different settings. So there's also an evaluation and a validation of the times that we provide with each intervention, that we are in the right way of providing not only the nursing language, but also the measured and validated time frame to go with every single intervention. So the next one, please. What I would like to show you now is really now the KPIs that are used in the institution who work with our classification. And this is an example of institutions that work with DRG, the diagnosis related groups. And this is an example of very simple, something tonsillectomy, and this is the cost versus length of stay. Down at the axis, you see the length of stay, and on the vertical axis, you see the cost. Now you can do that as the whole of costs, or you can just break that down on how much the nursing care costs. And to calculate nursing care, now if you know what is the total of care given in, because every intervention actually has a time frame attached to it, you can easily divide that by the cost of the nursing staff of every unit, and you know how much 1 minute of nursing time actually costs. So now you have this kind of chart where you see especially the outliers. And if I may ask you to show us the other slide, please, which is more of a complex situation. And you see here the long layers, the outliers. And if you go into the individual cases, which of course you can with a statistical tool, those are often cases who require a lot of nursing care. Might they have developed some kind of delirium, or they have been multimorbid, but nevertheless, whatever they required as a medical care, it is also basically they may have been bound to their bed, they may develop a high fever, they couldn't get out of bed, so the nursing interventions, they may have just been planned on giving assistance, but all of a sudden they had to provide a bed bath for the patient. But now you see that the time spent from the nurse with the patient has increased, and if you calculate costs, you see what kind of difference that makes. And also it is in terms of preventing these kind of patients to happen, or situations to happen, you see you have a different kind of charting than if you just have some kind of gut feeling that we know we have patients who require all different kind of nursing attention. And if I may show you the next slide, please. This is now the actual analytics tool that we use, which talks of the productivity. And I know in healthcare setting, this is a bit of a difficult topic, talking about productivity. We are not really in a manufacturer mode here, but also productivity in this sense means nothing more that we can actually spend most of our efficient time in nursing with the patient. And you can imagine we talked about documentation, so we document everything with the standardized classification, what the patient requires, and then we have like two elements of it. Either the nurses does not document the whole setting or the whole intervention, which is a lack in terms of legal side, because could be that many of the interventions got forgotten, but they have been done. But also we would actually have the possibility that a lot more has been done, and we can ask the question, is it necessary? We heard before with the lean management over the whole, is this something that is really required or not? And also all this is actually done on the backdrop of the nursing workload. So we are taking these 8, 9, 10 hours, whatever a shift is, and compare it with the minutes that have actually been done on the ward. And you see here on this kind of archway that most of it is in the green area, so that the balance between what was required from the patient and the workload that was actually there from the nursing staff was more and more one-to-one. And in the next slide, please, there is a different analysis. Now you see it in terms of every day. And we all know we have this kind of weekly changes. We have maybe days that is full surgery going on. We have the weekends. We have maybe days where a big physician visitation is going on. We learned about waiting times as well before. We learned about also maybe the staffing level has not been appropriate planned to the issues that had to be done on this particular day. So you see that very well. So from a managerial point of view, you see this, oh, what is going on days where I have a lot of unproductive time or overproductive time, red or yellow, so that I can really go ahead and work with these kind of graphs and data to optimize the service. And if I show you that in the next graph, what I mean, please, the next slide. Now, this looks on the first glance maybe a bit overpowering, but it is actually very easy to read. You see on the bottom the blue lines and the red, that is nothing else than the beds which are occupied, and the green mountain range, it's very nice, it's Switzerland, the green mountain range is the workload, or basically that is what has been done on the patient. And you see there's a little bit of a dimple, that is a weekend. A lot of patients went home on Friday, we all know that, and on Saturday, Sunday, the workload was a bit reduced. And on top, what you see, that is actually the available nursing time at each day of this month. So you see that actually the planning of this ward was not too bad. You see it, that basically they are more or less in accordance, so that at any time there was enough staffing there to deal with the workload that has been there. And also you see that the occupancy of the bed also have been more or less the same. Now you can imagine that if you have a chart like that and the green line crosses the black lines, or there is somewhere that the work time or the available work time of the nurses is not in any shape or form near this wonderful graph here, that you actually have a problem, and which costs the hospital a lot of money, as you can imagine. And so the next slide, please. What we do is we have the workload of each patient has also been categorized in different kind of, in 9 different kind of categories, ranging from a patient that actually only needs about 960 minutes per stay, to a patient that actually has 120 hours. So you see that basically the range of patients, and then of course, you know, you can only determine that at the end of the stay, because this is all calculated then retrospectively. But what you see is that how many patients did they have, and how intensive, and I don't mean intensive as in an ICU, but how intense their needs were on this kind of setting on this ward at any time. And you can imagine that just because a patient comes in for a hip replacement, depending on his age or his needs, this can really range from somebody who is basically happy to mobilize themselves again after 2 days, and you have maybe the 90-year-old patient who has who is bed bound for a week and therefore just had very little steps. Now this is also a different kind of occupancy rate, it's a different kind of attendance rate, tension rate of the nurses to the patient. And therefore, if we go to the next slide, please. What we can actually also see is the skill grade mix. When I talk about all these different settings, which is also very important that we have at any time the right person with the right education, with the right in the right setting. And that is what we find is also very important in terms of cost savings, or also staff satisfaction and patient satisfaction. And just one click more, because that should enlarge it, please. You can see it a little bit better. There you go. Thank you very much. So we have also this kind of monitoring setting. If we have a ward manager and she is responsible for all the managerial tasks, so we have the people, the colleagues who are responsible for the education of the students on the ward, and then we have the bachelor degrees, etc. There is no really benefit in this that a manager starts cleaning the bedsides or whatnot. So what we monitor with that, and you can imagine now if I plan and execute my interventions with my personal logging, of course, at the end of the month, I can also see who with which educational background did do which intervention in the end of the day. So if I go ahead and actually, next slide, please. Analyze the situation that I have on my ward. And this is what we have done here in this study, that we looked at the patient situation, because not every patient or not every patient situation really benefits from the same person who cares for them. Maybe somebody has to be in charge, that is clear, or has to be the person who actually does care plans, who actually does the overseeing of, or has the responsibility of the patient situation. But in the end of the day, who executes, let's say, a bed bath, or gives the patient, helps them with mobilization, etc., can it be somebody else? So we did analyze the patient situations and came up with this chart that is just an example of one ward, to see that if you have, for instance, a ward where you have many stable patients, it requires maybe less nurses with a master's degree, less nurses with a bachelor degrees, more to a normal with a nurse with a common degree. Or of course that changes if you have a ward where you have patients with high risk, where the situation of the patient, the medical side of the patient, can change very quickly, where you actually have to foresee also the pathway that he may slip into another situation, and you need the trained staff who actually is able to foresee, or actually then react in the right moment to do this. So moving on for that, I would just like to show you another analysis to do, please. This is a chart where we can actually monitor the individual interventions that are done on the ward. So you can imagine, if you have a clean professional documentation, whatever it has to be done with the patient has been documented and retrieved, so that you can not only have a time measurement attached to it, but you can also count how many times certain interventions have been done. Now, this is very interesting, because what everybody can relate to a situation, let's say a surgical ward, what do you expect would be number one issue on a surgical ward? Is it maybe mobilization? Is it administration of drugs? What would you expect? And you can imagine if number one would be finding a nursing home, or administer giving liquids or something, then, or just documentation, then you may have to ask yourselves, is it really, are they really doing the right intervention for the sum of patients on this ward? And this also, you can imagine that that is once used for quality control. Therefore, I can control, are they doing the right interventions? Are the right people doing the right interventions? But also if I have internal protocols, like internal standards, I have a standardized, let's stay with the hip replacement, if that is standardized in terms of on day one of the surgery, this is the plan that we do it in this way. Day two is the next stage the patient is going on, so that you could actually now in the analysis have a certain controlling, are these interventions really done, or are they doing something entirely different? Also, with this kind of charting, what we can do is, if you have, especially in large hospitals, what I find quite often is that when wards are full, or now especially in times of the COVID pandemic, that patients are put not on their surgical ward, but let's say put on a medical ward, or a pneumonia ward, and the staff is not really trained in looking after this kind of standardized procedures. Are they doing the same interventions nursing side as required? So you have this kind of excellent quality control in terms of not just the time charting, but also the issues of interventions. Yeah, next slide, please. Fortunately, I am at the end of my speech, and I hope I was able to give you a good overview what is done or what is possible in an electronic patient record. That is now, I would say, in Central Europe, state of the art, to have this kind of analysis, and also really reduces the time that especially nursing is using on filling out all different kind of papers, so that they can actually extract all the relevant information, whoever has an interest in the nursing data, and use it for their own purpose. Thank you very much.
Thank you very much, Ms. Susan, for this very, very informative topic. Are there any questions, please? If you have any question, you can write it in the chat box. Well, I have two questions for you, Ms. Susan. First,
yes,
you told about the clinical information system used documentation on different countries. In your opinion, what do you think the advantages and disadvantages for this using digital documentation? And what will be the recommendation for the future version of this documentation?
Yes, thank you. The advantage is certainly that we can actually use a lot of time in having just one core set of information. And I think that is really the key here, that we have one might it be an overview where we can fill in our information, also visible according across all the different professions. If I've been at the patient first, I may already asked about his setting at home, about his problem, and the physiotherapist doesn't have to ask the same questions again, or the physician doesn't have to ask the same question, and vice versa. So this kind of fundus of all information is gathered in one particular tool. And also, if everybody actually uses the same standardized language, it is so much easier to then extract all different statistical data. I think nowadays we have so much requirements. We have to deliver on a national level all different kind of data, but also now with COVID, we may want to participate with SNOMED. We want to tell them on basically on how many, how much, etc. But what's also always gets a little bit missing is the time of the people who execute it. In this case, it's the nursing, isn't it? That we can prove what we're doing really. And before in the speech, it was all about also the appreciation of the nursing staff. And I think with this tool or system method, you can actually prove what we're doing. It's not just something that we're telling and saying, oh, it's a heavy workload, but we can actually prove it in saying, look, this is how intense patients are, and they require so many hours in nursing care, and this is the staffing level that we have, and we have, usually it is not enough staff to cover what we actually need in terms of nursing care on the wards.
Yeah, go ahead.
And you're sorry?
Yeah, go ahead, please.
Sorry?
Go ahead, please. I'm listening.
Okay. I think that's really the benefit. And also on another point of view, especially we're here now from so many different nations, but we all care for a human being in the end of the day, and there are so many approaches to that. And it would be really interesting, and I think that's our next task, to then compare what we're actually doing with the patient to find the best possible way forward, the best possible pathway also, because there are, just in the countries that we work now with, there are so many differences also in terms of how patients are treated by nurses, what is deemed necessary by nursing staff, what has to be done with patients. And I think that is also something, this benchmark, to really start comparing on an international basis. I think that would be also amazing to see.
That will be amazing. And regarding COVID-19 situations, patients, how do you cope with this regarding documentation?
I have to say the colleagues actually love it, because the big advantage is if you plan, if you're clever planning what the patient requires, or you can actually, if you have internal pathways, you can plan that in advance, so that the administrational task is actually reduced. Because in the following days, you just have to go over, you have to say, yes, I've done that, or I have to change a little bit the time maybe, or 1 person, 2 person. And the feedback that I get is that they now have done pathways, of course, for the COVID-19 patients in terms of different varieties of it, and that they find it quite also a help, because it can show them also in terms of a guideline. What do I need to do? Did I really have embraced everything? They find it quite a help. Yes, and of course, when it comes to negotiating with, in Switzerland especially, the health insurers, it gives you a really good analysis to negotiate with the health insurers on how much treatment costs in terms of COVID, because that was here before.
Okay, we have one question from Prof. James Jordan. He's asking, has this data uncovered a supervising critical success factor for a successful outcome?
The data actually, yes, there are some surprising finding in it. I think that is also a very nice or nice side effect in terms of clinical trial or research, really, because now, as you can actually prove or have this kind of deep insight what nursing is actually doing, this has really found some kind of findings that nobody really was expecting, because there are many tasks that nurses just on the go on a daily basis that are never really either recorded or not have been added with much value. And now also these kind of tasks came to light, which I think is really helped with the appreciation of the nursing staff and what they're doing. Yeah.
Thank you, Ms. Susan. Any questions, please? Actually, we don't have any more questions. I would ask